This one's, I think this is actually the camera to zoom in and zoom out. I think I can check. Let me check, I can ask.
Okay.
Okay, but you should be recording by now, so it should be recording.
Okay,
Okay,
great.
so I'll be back.
Okay, well, welcome, folks. Got a huge amount of material, and I'm not going to obviously cover it in a minute, but I'll give you a taste for violence risk assessment, okay? Okay. Concerns about predicting violence. First of all, I would assume from your young faces, none of you have been actively involved in violence risk assessment yet, right? Okay, good. Okay. When I originally started this off, it just had Virginia Tech there. You can see how long we have been doing this presentation. But unfortunately, we get all of these other kinds of things. The one in Aurora, Colorado, Sandy Hook School in Newtown, Connecticut, and many more that can't even hope to mention. One of the issues in these is the whole issue of mental illness. And like, probably with Sandy Hook being the most recent, good.
Thanks for help advancing the slide.
Oh, yeah. Can I advance? How do I advance? I can see. Which is next? That's next.
Okay, so push R, we have to push R.
Oh, okay, that's all. Okay. Okay. Will it do it from here?
Yeah.
Okay. Because I prefer to be sitting down. Okay, great. Okay. Okay, there we go. Okay.
Yes, maybe pointing to my
Pointing to. Okay. Okay. So you may recall with the Sandy Hook shooting, lots of people were saying, "Oh, this kid Adam Lanza, he was mentally ill. He had Asperger's." So people were going into panics about, "Oh, my child has been diagnosed with Asperger's. Is he going to be mental? Is he going to be violent?" And of course, there's absolutely no literature, no correlation between Asperger's disease and violent behavior. In fact, going back historically, the role of mental illness has been tremendously misunderstood. Of course, the media always plays it up. Mentally ill client acts out violently. In point of fact, with certain exceptions that I'll talk about in a few minutes, mentally ill people have no higher rate of violence. Their base rate of violence is no higher than violence in the general population. Okay, I don't know if that surprises anybody.
Yeah.
Okay. And that's about 2%. If you were to take 2 out of a random group of 100 people, 2 of them would potentially be violent. If you took 2 people out of 100 psychiatric patients, 2, would have the potential, for future violent behavior. So that actually was one of the earliest misperceptions. And in fact, as we'll talk about in a few moments, the original idea was this person sits down with a clinician examines them, and if they're mentally ill, then there's a significant risk of future violent behavior. As we'll find out, that's not at all the case. There were a lot of concerns raised, controversies regarding our predictive ability. A very upsetting, you might say, disturbing study came out around 1980, 1981 by a guy who was to become a very prominent researcher in this field, a guy by the name of John Monahan, who was and has continued to be now a professor at the Institute for Law and Public Policy at the University of Virginia. Back around 1980, 81, Monahan did a meta-analysis of all of the research studies that were available at that point in time about our ability to predict future violent behavior. And there was this mistaken belief that we as mental health professionals were highly accurate in our ability to predict future violent behavior. In fact, Monahan's research showed that we were accurate only 1 in 3 times. About 33% accurate, which meant that we were wrong 2 out of 3 times. And when you stop and think, you say, well, so what, big deal. But you stop and think about what some of the implications. Where does assessment of violent behavior come in? Well, when a person gets arrested, part of the decision whether or not they will be released on bond has to do with their, quote, potential dangerousness. If you are concerned about a mentally ill patient and you want to involuntarily commit them into the state called the Baker Act, danger to self or others comes in there. If they are to be released from a psychiatric facility, are they no longer a danger to themselves or others? Same criterion applies if somebody is found not guilty by reason of insanity. Are they no longer a danger to self or others by reason of that underlying mental illness? The idea when somebody served their prison time being released on parole, danger to self or others is one of the major features. And perhaps most disturbing, for me anyway, is in many states, one of the criteria for whether or not a person can be executed, is whether they will be a future danger, whether they are likely to act out violently in the foreseeable future. So that's a pretty irreversible kind of thing. And if we are wrong 2 out of 3 times in our ability to predict violent behavior, really raises, some very strong moral, ethical, psychological concerns, across the whole board. So people started thinking, well, maybe psychiatric status isn't enough, which is why the last bullet point, need to consider all relevant variables. People like Monahan started saying, well, maybe we need to look at things beyond clinical status, because clinical status really, takes care of a tiny minority. Okay, so I'll try to stand for as long as I can. So, early beliefs. This one, the first was that we were accurate, and that you have already covered this. Okay, actually we've covered all of those, just in my ramblings. So let's go. Now, Monahan in the mid-1980s started in with this project called the MacArthur Foundation Research, and it was research into assessment of violent behavior. You may have heard of the MacArthur Foundation. It's this huge think tank, very, very well funded, and they found lots of stuff in the area of mental health law. There's a competency assessment research, a competency to consent to treatment research, and one of the big pieces of research was this violence assessment. So what they set out to do was to take a look at the entire range of variables that could possibly be associated with violent behavior. And in looking back on these early studies, what they found, interestingly, were 3 problems. First, what they called impoverished predictor variables. In other words, just trying to predict for mental status obviously wasn't working. We weren't looking at enough predictor variables. We were looking just at whether or not the person had a mental disorder. Clearly it was not enough. And secondly, impoverished criteria, or criterion, outcome variables. The outcome variable that was used as equivalent to dangerousness was whether or not the person was arrested. Okay, just tell me off the top of your heads, why is that not adequate? An adequate definition of dangerousness, whether or not a person is rearrested. Why is that not good?
You don't have to be violent to get
Sure, you don't have to be violent to get arrested. And what's the flip side of that?
You can be violent and not.
You can be violent and not get arrested. What kinds of violence most often does not lead to arrest? Domestic violence, absolutely. Lots of stuff is just kept quiet within the family or isn't treated as violent behavior that needs to come to the attention of the police or the courts. And finally, failure to consider effective intervention. What they found was there was nowhere in the early methodology to say, well, we thought this person might be at risk, but they got some treatment, they went into a hospital program, they went into a substance abuse program, they started therapy, they got on medication, whatever. That was not part of the issue at all. So they identified these three issues conceptually as reasons that our predictive abilities were poor. So what the MacArthur studies did was to take a look at all of the literature regarding ability to predict violent behavior. And what they found is that there were 5 very distinct areas of writing about and research about violent behavior. The psychological, the sociological, biographical, demographic, and contextual. And what most researchers were doing up until this point in time was focusing on 1 of the 5, or at most 2 out of the 5. But never looked at interaction effects, never looked at the entire list of variables. Ultimately, these were basically the domains that, when they said, sort of in a shotgun approach, okay, what are all the variables that have some correlation with violent behavior? They came up with, and keep in mind, prior to this time, we had been looking at 1, whether or not the person is mentally ill. They now discovered in this MacArthur research that there were 38 independent variables that went into an assessment of violent behavior. And these 38 dimensions or parameters pretty much broke down into these 5 areas: psychological, sociological, biological, demographic, and contextual. So let me talk a moment about some of them. Let's flip the order around, because the demographic pretty much comes first. Those are the very basic anchoring points. Things like age, sex, socioeconomic status. Used to be thought that race was one of them, but when they controlled for socioeconomic status, the racial factor pretty much dropped down. So, age. The age of the highest likelihood for violent acting out is between ages 18 and 24. Okay, so if you have a client you're assessing between the ages of 18 and 24, immediately that puts them in the high-risk category. Each of these can be modified by other kinds of variables. Okay? Sex. Men act out violently more often than women. So being a male between the ages of 18 and 24, just from a demographic point of view. And let's add, low socioeconomic status, poorly educated. Those are 4 demographic variables that are predictive of violent behavior. As we'll see in a moment, some of the predictive systems that have been developed focus exclusively on these demographic or actuarial or static variables. And what I hope we'll carry away from here is while some people like to believe that makes the whole thing very clean and doesn't muck it up with any sort of, clinicians' hunches and intuitions, it's really inadequate. We know that prediction of violent behavior is much more complicated than just what these demographic variables show. Okay, then we get to the psychological factors. And these are some of the things that we've talked about before. Diagnosis, okay? But that is qualified somewhat. Being mentally ill in and of itself is not a good predictor. As we said, it's about the same as the base rate in the general population. What they actually found was more predictive of violent behavior than mental illness were personality disorders. Okay? Most specifically, personality disorders, if you sort of look at it from the point of view of the theorist, what is called the narcissistic borderline antisocial continuum. That cluster, I forget DSM, whether it's that cluster B or cluster C, whatever it is. That cluster but the borderline and narcissistic, within which falls the concept of psychopathy. And if we have some time, I'll talk later about what psychopathy is all about. But, that psychopathy is sort of a subset of that kind of categorization. Substance abuse is very, very highly correlated. Matter of fact, when you find risk factors, if you define and say this person is 20% likely to act out, if they are also involved in substance abuse, and even more specifically, if the substances are used as an alternative to treatments, the person is self-medicating, that boosts that predictive value by a factor of 3. So somebody who has a risk factor, say of about 20%, if they have a significant substance abuse history, it immediately jumps to 60%. So it's a very, very powerful predictive factor. Also, obviously, past history of violent behavior. Not a great, doesn't take a great rocket scientist to know that prior violent behavior was predicting future violent behavior. Okay, so those are some of the psychological dimensions. Now, there's a whole body of literature that takes a look at sociological dimensions. Sociological dimensions such as the family structure. Does the family structure act in a way to legitimize, to validate, or to inhibit violent behavior? Does the child grow up in a family atmosphere in which violence is seen as a legitimate way to solve problems? So what's the family history vis-a-vis violent behavior? And of course, though people will sometimes say it's a private business matter, don't pay attention, domestic violence comes in there. What are the role models that the person has growing up? Is beating somebody up a legitimate way of dealing with problems? Same sort of thing goes for the peer group. Does the peer group legitimize and validate or inhibit violent behavior? One of the other things, and the employment stability or lack of stability. A whole other body of literature that talks about lack of employment stability, job loss or threatened loss of job, or unemployment. These are, of course, all highly correlated. Not highly, but I mean they are risk factors. One of the other things coming under the sociological, what a colleague of mine by the name of Dr. Reed Malloy has spoken about, and he talks about a whole thing that he calls popular cultural influences. And of course, a popular cultural influence that should surprise no one is the influence of firearms. Okay? And whatever your position on, Second Amendment rights here are basically irrelevant. Okay, the simple fact is that more violent deaths are caused by firearms than by any other kind of weapon. Okay, so what is the person's skill level in terms of handling firearms? How many firearms do they have? And perhaps most important, what is their affective relationship? What's their emotional relationship to firearms? You might say, how on earth did you determine that? Well, one thing, Malloy says, and he's developed the thing called the Weapons History Assessment Method. If you look at the initials, it's called WHAM, W-H-A-M. It's Malloy's Weapons History Assessment Method. If you add, Dr. Malloy has absolutely no proprietary interest in it. He's a very lovely guy. If you were to email him and ask for a copy of the WHAM, he would be delighted to send it to you. But the WHAM has, in addition to the standard kinds of questions, how long have you used firearms? How many do you have? How often do you use them? What do you use them for? What do you read? What do you like to? How many magazines dealing with firearms do you read? Like Soldier of Fortune magazine. Do they read True Detective magazine? Things of this sort. So Malloy does makes an effort to assess those as popular cultural influences. And you might say, how do you get the affective tone? Well, sometimes you do, sometimes you don't. I'll share with you a story. I was skeptical of this originally, but, Dr. Malloy was a trusted colleague whom I had known for many years. So I was asked to do what's called a fitness for duty interview, somebody concerns about potential workplace violence. So they sent this guy to me for an assessment. He worked for a large chain of grocery stores, something like Publix. So this was in a different state, so it wasn't Publix, but something like Publix or a big city. So it was very obvious from the moment the guy came into my office, he didn't want to be there. He wasn't going to give me any information. Anything I got from him in the interview was just very, very limited. And I said, okay, well, let me turn the focus of the interview. Tell me, do you have guns? Oh, yeah. Boy, do I have guns. And all of a sudden, his affect brightened. He started smiling. He became animated. I said, tell me about your gun collection. Oh, I love my guns. They are my favorite friends. I love to pull them apart. I love to clean them. I just get such a charge. And I mean, he's almost, pardon me, he's almost having an orgasm in my office. It's just like, this is just the most exciting thing in the world for him. I love to clean them, and I love to, and I've got 10 lots, and I've got this and that. Well, that told me a lot about this guy. So that's the issue of the sociological. From a biological point of view, there is some research literature that says that what we call affective aggression, sudden outbursts of aggression, as opposed to predatory, which is aggression where somebody stalks somebody and kind of plans things. But affective aggression, sudden outbursts, can be caused by head trauma. People who have sustained serious head trauma have been seen to be more irritable, more overreactive to certain kinds of situations that most of us could pretty much let roll off our backs. So you take a look at a possible history of head trauma. You do some sort of neuropsychological assessment. If you're not trained in that, try to refer it to somebody. Again, if they have a history of head trauma, you want to look at that. Okay, now finally the contextual. Violent behavior is very rarely random. Quite occasionally you get it. Somebody just goes around in an automobile shooting out the window of their car at, strangers. That happens, but it is in the minority. Most often, aggression is targeted aggression. So there are certain people, groups of people, areas in which people reside, whether or not the person is intoxicated at the time, whether or not they're under the influence of drugs. These are all contextual variables. Do they commit violent behavior within the family or outside the family? In the workplace, outside the workplace? These are things, that we refer to as contextual variables. So that's another thing that you have to determine by careful analysis. Where does the behavior most likely occur? Are there any consistent patterns that you can see in this violent behavior? Okay, so you can see just how complex an undertaking this can be. Oh, the emphasis on probabilistic statements. It's a whole paradigm shift, because in the past, the question asked of us as mental health professionals was, is this person dangerous? And as you start to look at this in terms of so many factors, the question of whether or not they're dangerous is really a meaningless statement. It's really, what is the potential for violent behavior? In other words, how many of these risk factors, how many of these 38 risk factors does this particular individual possess? Now, unfortunately, our science is not so good that we can say, if they have 18 or more risk factors, they're at high risk. If they have 11 to 17, they're moderate risk. So those are still clinical judgments. But clearly, the higher the number of risk factors, the more you have to be concerned with. And since you're not always sure what the context of the behavior is going to be, you use probabilistic statements. This person has a high likelihood of violent behavior. This is how you would state it. A high likelihood of violent behavior if within family settings while intoxicated. They are less likely to act out in non-familial settings where there is no substance abuse involved. The advantage to conceptualizing it that way is the fact that now you can make interventions. So if the family seems to be a problematic issue, maybe some family therapy. If substance abuse, maybe some treatment with substance abuse. But looking at it as a series of risk factors rather than a dichotomous statement, they are or they are not dangerous, helps you tailor your intervention or management kind of strategies. Let's see. Okay, we talked about this. The thing about the third bullet point here, expanded methodology. In addition to the arrest records, they started looking at records from all sorts of other areas, like psychiatric records, other kinds of treatment records, social service, intervention, and they actually sent out, MacArthur researchers sent out cohorts of interviewers to actually sit down with family members of people who had been in psychiatric facilities before had been released, and they did in-depth interviews to see what the behavior within the family was, whether or not it was reported to the police. You know, so did the person make threats without acting on them? Did they make threats and wave their arm around in a threatening manner? Did they make threats and hit with an open hand? Did they make threats and hit with a fist? Did they use a weapon? You know, broken down just that finely. Okay, so we talked about the conceptual shift. Okay, we've covered all of that. Okay, we've already talked about. One of the things here mentioned size of the potential victim pool, and that was the issue I mentioned before about whether or not the violence was random or there seemed to be a particular pattern. Okay, under psychological variables, poor impulse control is one of the other things that we looked at as a psychological variable. Take a look at this, getting back to the role of mental illness. I had mentioned that the original thinking was that it was highly correlated. You know, if you are mentally ill, you are by definition violent. And of course, that's what the media still plays up. However, the initial range of research, Monahan and others, as I said before, showed that in general, across all psychiatric diagnoses, that is probably still an accurate statement. But Monahan was a scrupulously honest researcher and said, well, there still seems to be, when you look at these cases reported in the media, still seems to be a psychiatric history in some of these people. So maybe there are some diagnoses, if you pull it out of the overall pool of mental illness, that do seem to be more highly correlated with violent behavior. And in fact, he found out that there were some. So, anyone want to take a guess at what some of the diagnoses were that Monahan described as having a modest correlation with violent behavior that raised it above that 2% base rate? What kind of diagnoses do you think might go in there? Anybody?
Bipolar?
Yeah.
Bipolar 1?
Bipolar 1. Affective disorders in general. But yeah, bipolar 1. The person gets agitated, gets high, poor judgment. Yes, that is one. What else?
Schizophrenic.
What?
Schizophrenic.
Not schizophrenia in general. No, but a particular kind of schizophrenia.
Paranoid.
Yeah, paranoid schizophrenia. And various paranoid delusional states. Those seem to be correlated. And then the third one we have already touched on, which is the substance abuse. So those three, as diagnoses, as does the, don't know really whether you want to call it a mental illness or not, but the personality disorders that we talked about before. And in the paranoid systems, they stress the particular kind of paranoid thinking. Not all paranoid thinking goes into it, but what is described by some of these researchers as thought control override. This seems to be a particular kind of delusional system that has more correlation with violent behavior than others. So thought control override is the person who has a belief that they are somehow being controlled by an outside force or forces, and that they are powerless to overcome that influence. That's what's called thought control override. So if a person has a belief that the Al-Qaeda is, I have to update, it used to be that the communists are polluting our water supply. Okay, let's say that Al-Qaeda is polluting our water supply. That may not particularly have any particular correlation, with being a risk factor for violent behavior. If you say something like, Al-Qaeda has a machine that they aim at my head from great distances, and that machine makes me unable to think, and there's nothing I can do to overcome the influence of that machine, that would be the kind of delusion that would be more likely to lead to violent behavior. The thought control override delusion. And individuals who believe in this thought control override are always looking for external confirmation. Of course, their confirmation really isn't confirmation, but here I'll give you a perfect example. Luckily, this case did not result in violence, but it could have. I examined a defendant many, many years ago who had the delusional belief that two organizations, Freemasons and some obscure religious group called the Davidians, had somehow teamed up and that they had a thought control machine, or actually just a machine, which when they aimed it at him would cause him intractable physical pain. And there wasn't anything he could do. He just wrote letters to representatives, to congresspeople, to local politicians, to national politicians, to stop these people, to pass a congressional bill outlawing these mind control machines, because they were destroying him. They were, making him impotent. They were making him incapable of working, and so on and so on. This mind control machine was having a terrible, terrible effect on him. He even went to see a therapist, which is what I talked about, external confirmation. And the therapist, he was convinced that the therapist believed in the conspiracy. Why? Because the therapist said, "Tell me more." Okay, so that meant that's the external confirmation. Any rate, what happened, and this was way back in the around 1994, 1995. It was during Bill Clinton's presidency. So he decided, look, I'm getting no satisfaction. The president will help me. So he wrote this crazy, rambling letter to President Bill Clinton. And he gets back a form letter, of course, from the Oval Office, saying, "Thank you for support of my policies." So now Bill Clinton obviously knows about the Midian Freemason conspiracy. So he decides, great, President Clinton and I are going to fight off these evil forces. So he drives from his home, which happened to be in Wichita, Kansas, with a trunk full of weaponry and like 200 to 300 rounds of ammunition, all packed into his trunk. And he was going to stop at the White House, pick up President Clinton, and the two of them were going to go fight this holy war, the jihad, against the Midians and Freemasons. He got as far as the Northwest Gate of the White House. Secret Service said, what's your business here, sir? And he told them that he and President Clinton were going to fight the Freemason Indian conspiracy. And they said, by the way, the Secret Service are very cool guys. I used to do all the training, what are called protective research briefings for identifying mentally ill people who come to the White House. Really sharp guys. So they said, well, how do you intend to do this, sir? He says, oh, I've got my arsenal in my trunk. Would you show it to us, sir? He lifts up the trunk. He's carrying all of these illegal firearms. So they arrest him. The guy is clearly severely mentally ill. And he gets found out guilty by reason of insanity. But this is an example of the thought control override delusion and the external confirmation. Okay. Had he not been arrested, then there could have been, had he not been stopped at that point in time. That is the kind of delusional thinking that could have led to violent behavior. Even then, even with the thought control override symptoms, our predictive rate, that raises the base rate of violent behavior from about 2% up to about 8%. So it's a modest correlation, but it is somewhat higher than the across all categories. Yes, sir.
I haven't done much research on it, but I was just wondering if there's, as far as the variation of the crime itself, would the mentally ill be more predisposed to committing mass murder crimes as compared to the guy who thinks his wife is cheating on him, or gets in a fight with his neighbor, or kills to rob?
It's a great question, and not so much. There's really no good research data that I know of, say mass murder or certainly serial killings. No, mass murder is where you kill a lot of people all at once.
Right.
There's really no, it sounds like that is something that a mentally ill person would do, but there's not any really good research data. What comes to mind is something that may be way before your time, but back in the 1960s, there was this guy named Charles Whitman who went to the top of the bell tower at the University of Texas in Austin and just shot automatic weapons and killed a whole bunch of people on the University of Texas campus. And it turns out on autopsy, it was discovered that he was suffering from a brain tumor. But I think that that's the exception rather than the rule, There may have been other cases, but we don't know. But there really does not, with the exception of certain kinds of really crazy kinds of crimes based on a delusional system, there does not seem to be any necessary correlation. Okay? Okay, so we're running short on time. I just want to quickly give you some of the different approaches that are being used now. Now, the clinical is what we talked about before, which turned out to be so unreliable. You just sit down with an individual, do your clinical psychological evaluation of him or her, and come up with a feeling, basically, of whether or not they are likely to act out violently. And that is down around, that's about the 30%. We seem to be wrong 2 out of 3 times when we do it from a purely clinical point of view. Now, as a reaction to that, and as a matter of fact, even suggested by John Monahan, was the actuarial assessment. And there has grown up a real cottage industry of all sorts of actuarial assessment instruments. What it does is to take these demographic static variables like age, sex, socioeconomic status, history of alcoholism within the family. Did the person live with both biological parents until the age of 16? History of nonviolent offenses, history of violent offenses. Was the victim of the offense male or female? This is done with the male population. And again, sometimes it doesn't make any sense. On a purely statistical basis, male-on-male violence is more frequent than male-on-female violence, with the exception of sexual violence, of course, and that's a separate kind of category. But so it takes these issues. Interestingly, it has a category called they say schizophrenia. Okay, and they say schizophrenia surprisingly has a negative correlation. They never broke it down into the paranoid types or others, but they say schizophrenia generally across the board has a negative correlation with violent behavior. Substance abuse, of course, positive correlation. And the construct of psychopathy has a high correlation with violent behavior. Right? We're not going to have time today to talk about psychopathy, but I'll just mention to you, there is an assessment instrument called the Psychopathy Checklist, PCL, and its revised version, PCLR, Psychopathy Checklist Revised. And it basically is a structured interview that goes at the two primary dimensions of psychopathy, one of which is, not surprisingly, antisocial behavior, repetitive history of infractions of the law, what's called criminal versatility, acting in various different kinds of criminal behavior, a parasitic lifestyle, living off of other people, many short-term marital relationships, the inability to have sustained intimacy in a relationship, many having losing, the loss of jobs, things of this sort. That's or financial irresponsibility, basically. And then factor one, which is called the interpersonal dimension. Grandiose sense of self-worth, callous, unemotional, the externalization of responsibility. It's always somebody else's fault. Those are the ones that come to mind. Give you a sense of inability to learn from experience. So those are some of the interpersonal dimensions. That construct taken together, factor one and factor two, factor one being the interpersonal, factor two being the antisocial. This is supposed to be a very robust predictor of violent behavior, both in the general population and in a mentally ill population. So, the concept of psychopathy figures into the actuarial assessment a lot. Now, people who say you do the actuarial assessment and that it's so much better than clinical assessment, well, yes, and then again, no. Depending on which actuarial assessment instrument you use, the predictive validity ranges anywhere from 35 to 44%. Okay? So it's really, it's a slight improvement over clinical judgment alone, but it still isn't that great. There's been a lot of hype about how great actuarial assessment is, that it's scientific, that it doesn't get muddied by, these ridiculous things called clinical judgment. That it's scientific and highly predictive. Well, it's not highly predictive. Predicts maybe a little bit better than clinical by itself. So some people say, well, let's use what we call an adjusted actuarial approach. What we do is start off with the actuarial and then refine it with various clinical dimensions. And then the actuarial assessment can either go up or go down. Well, again, this hasn't shown to be very effective, and the people who do actuarial say, it's really just turning it back into clinical. So it never really, got any big following. So the most common approach now is what is called structured clinical judgment, or sometimes called structured professional judgment. What this does is to take the dimensions that the research has identified. So let's say our MacArthur research, which has identified those 38 areas. And structured clinical judgment says, here are the 38 areas that we know to be correlated with violent behavior. You, as the clinician, sort of use this as a checklist. But you can use anything that you want, anything that you as a clinician feel comfortable with, to basically fill in each of these 38 dimensions. So it uses your clinical judgment, but it's structured in terms of the available research. Let's see. I gave you some examples of the violence risk assessment. The actuarial variables I gave you before came off of the violence risk assessment guide. Let me jump ahead a few slides because I know we're running out of time. I'll give you an example of some of the dimensions that show up on the PCL. Oh, by the way, let's take a look. These some talked before about psychopathy, and I was trying to create them from memory. So, glibness, superficial charm, grandiose sense of self-worth, need for stimulation, pathological lying, conning, manipulative, lack of remorse or guilt, shallow affect, callousness, lack of empathy. So those are pretty much the interpersonal. Then the others, the parasitic lifestyle, promiscuous sexual behavior, and so on. Those are the more antisocial. Okay. Here, the HCR 20 is an example of the structured professional judgment. It is 20 items and used to inquire. Now, you might say, what happened to the 38 items that MacArthur has identified? Well, it's pretty much the same. They've just been condensed, organized differently. So this is one of the more popular of the structured professional judgment. So you can see how young the person was at the time of the first violent incident, early examples of maladjustment, abusive background, employment problems, substance abuse, major mental illness, psychopathy, so a lot that we've already covered. Then the clinical variables, lack of insight, negative attitudes, primarily towards justification of violence. So it goes fairly detailed kind of interview. The person is saying, well, you know, I only hurt people who hurt me first, or she had it coming, or attitudes of those sorts. Those are predicted. Active symptoms of major mental illness, impulsivity, lack of responsiveness to treatment, and then the risk management items. Plans lack feasibility. What does the person say they're going to do when they get out of the hospital? Are there destabilizing influences? Are they likely to go back into the very environment that seemed to stir them up in the first place? Are they likely to go back to the substance abuse? Lack of personal support, or, you know, a positive would be that there is personal support. What is the family, what is the structure like that they can be in? And what is the likelihood of increased stress? So those seem to be the HCR 20, which is really, I would say, perhaps the most widely used of the structured professional judgment now. These are some more detailed, I'll just quickly mention them. SARA stands for the Spousal Assault Risk Assessment. So this is used, and you can just read this on your handouts. It's a checklist. Okay, I guess that's the end. I had a lot more stuff originally. Okay, I've zipped through this. I'm sorry for having to go so fast. Questions? Anything? All ready to go out and do risk assessments? No. Oh, by the way, the final, it's good news and bad news, which is the fact that when you do one of these comprehensive assessments, the research has shown that we're now significantly better than the 1/3. But still, it's not great. We're up somewhere between 50 and 60% accuracy. So we still may have 40% error, even at the best. Now, that, of course, is in the aggregate. Those are across all kinds of cases. And this is an interesting, different way of conceptualizing it. So across the board, if we do a comprehensive assessment, we can say be between 50 and 60% accurate. But in any given case where a lot of risk factors apply, then we might be, a good deal better. Or there may be some cases where we have very few risk factors and the stuff might not apply at all. So one of the issues conceptually to consider is, should we, as evaluators for courts or for other outfits that ask us these questions, should we be free to say, this is a case in which I can give an informed opinion because I could really study the different risk factors involved, as opposed to, this is a case where, there's just not enough good information, so I can't really make an assessment. This would be my preference. Unfortunately, when you get, a court order to do an assessment, they don't say, assess if you have enough risk factors. They expect an assessment regardless of the number of risk factors you have. So then becomes an issue, really an ethical issue. Remember, ethically, we can only respond to something when we have sufficient data to support the opinion. So if we take a court-ordered request like that, and we don't have enough data to give an informed answer, what should we really do? Should we just turn down the referral and say, sorry, can't help you? Or say, right, there's not enough information available? Because you know what will happen if you don't? It doesn't solve it. You will be acting in a highly ethical manner, but it just means that they'll send the referral to somebody who's got less integrity and fewer professional ethics than you, and the ultimate outcome might be quite harmful, because that person doesn't give a damn about whether they're being ethical or not, and they'll just give an opinion on potential for violence risk without doing it. So in a sense, you maintained your own reputation, but are you really assisting the court in letting them depend upon somebody who doesn't really care about the scientific basis of the opinion? So I'll let you folks think about that. It's an issue I've been chewing on for many years. I've written some about that, but requires a lot of thought. Okay, any final questions? Okay, thank you. Go on, and I hope you...
Shapiro, I do have a question. I'll chat with. I work with children in the school system, and I noticed that a lot of the behaviors were impulsivity.
Yeah.
And thank you. Oh yeah, actually hold on to it. Okay. Thanks. Preventatively, what can we do? Because I know you said the ages from 18 to 20. Or when we kind of look at can we, if we see impulsivity and we see that some of the behaviors at this young age, because I'm in the speech language technology program, can I we preventively do some?
Well, yeah, but, you know, that becomes problematic too, because, you know, then some people will raise the issue of whether or not you are, you know, prematurely diagnosing someone and labeling them for the rest of their lives, you know, so.
Yeah.
No easy answer. You know, I think certain things that you do want to identify. Now, unfortunately, some people are now saying we can identify psychopathy in 4-year-old kids. You know, they can call a 4-year-old child a psychopath.
Yeah,
That's going to follow them the rest of their lives, and that can be very, very destructive. So,
right. And then they almost live,
Yeah.
because you're calling them, they're like living that because
exactly.
you've named them that,
Right,
yeah.
right.
They have something to uphold.
Okay.
All right.
Let me just run to the restroom.
Sure.
I think we've got a few more people coming in.
Handouts are here. I'm gonna run to the restroom too, but other people, I don't know how many people are coming. Also, if you still have the surveys, there's a section for the breakout session too. You can give them, actually put them on the lunch table, like right at the lunches. There's a little basket for them, if you don't mind.
Session is over.
It's about to start again.
Okay, looks like this is us. Let me just, I forgot to mention it to the last group, but you may know, after we're done here, we'll go back into the large room for sort of a wrap-up session. Okay, so let me talk a little bit with you about the whole issue of violence risk